Cool. Thank you very much, Sarah. Thanks for asking me to be here to speak tonight. I'm really excited. I thought I'd be super nervous, but I'm actually just so excited that the nervousness is like, I don't know where it went. Anyway, I wanted to thank Sarah. I also have to thank Yvonne. I don't know where Yvonne, she might be out, just waiting for people to come in, but Yvonne was really helpful getting everything organized here this evening. And of course, all of you for being here. Thank you so much, and braving the freezing rain to be here. And also all of you at home, the virtual attendees zooming in, thanks for being here. I have notes with me because I'm just recovering from long COVID, so bear with me, I'm going to be referring to these. I agreed to do this talk tonight for two reasons. So first and foremost, because I love active life conditioning. This team has been a huge part of my health journey the last few years. Sarah's coaches and her therapy team really are the best in the biz. And I want to give a special shout out to my trainer and nutritionist, Jess, who I've been working with for about 3.5 years. I don't think she's here tonight, but she will be speaking in the coming weeks as part of this program. And also, when I heard about Active Life 2.0, I immediately signed up. So that's why I'm all sweaty and wearing this. I was just in that room lifting heavy shit. So, and the reason that I'm so excited about that is because when you're approaching midlife, muscle is medicine. It's actually hugely important, really underrated. And so I signed up immediately, was happy to get a spot. And these are my girls over here that I'm lifting heavy shit with every week, twice a week, and Brandy, our trainer. And number two, so the second reason why I agreed to do this talk, because all of you deserve to know what I'm learning about. So all of you deserve to know what is up with your hormones and your health in midlife. I'm a student of menopause medicine and midlife healthcare. I'm by no means an expert yet. I'm a student, but what I'm learning is just so important for all of you to know that I'm like, heck yes, I'm going to be here. I'm going to show up and I'm going to share what I know. It's really confusing. There's a lot of information, as Sarah alluded to. It's cloudy, it's confusing, it's controversial, even for doctors. So whatever profession you are in, it's confusing. There's a lot of new information, there's some old information, a lot of controversy. And there are studies that have been published recently that show that even like medical doctors, even gynecologists, feel like they're ill-equipped in some cases, especially when they're like freshly out of school. They feel ill-equipped to manage women in menopause. So if they're feeling, what does that mean for womankind? There are so many issues related to women's health. It's kind of shrouded, menopause is shrouded in secrecy and shame, suppressed and made fun of by misogyny, skewed by the media, sensationalized by the media. It can be really hard to know who to listen to, who to trust. It's important for us to know what's up with your hormones, what's up with your health in midlife. We're living longer. Us women, we're living longer than ever before. We are spending more years post-menopause than ever before. And I want to share a really crazy statistic with you. By 2025, like not very far away, there will be 1.1 billion women in menopause. The world has never had that many women in menopause before. And like, right? Isn't that staggering? 1.1 billion women in menopause. Talk about global warming. So menopause affects your life. It affects your home life, your work life, your social life, your sex life. It affects your whole life. 50% of women don't seek care for their menopause-related symptoms. Half of us don't seek care for symptoms that are related to our menopause, and we have to change that. And the reason we need to change that is not just because, like, you know, we don't want you to suffer unnecessarily. Like, that's a pretty good reason though, like, don't suffer unnecessarily. I like that reason. But the other reason is that when we don't address your menopause related health concerns, if you don't get those things managed and treated, you actually have an increased risk of illness and death. I'm going to say that again. It's not just about your quality of life. It's not just about your sex life. It is about preventing illness and preventing premature death. And this is based on science. I'm happy to share all the references and resources with you today. I'm not making this up. Pretty crazy. So put up your hand if any of that is new to you. Like, if, okay, right? So like that's, and I felt that way earlier, or I guess I should say last year. I've been heavily investing in my education around menopause care. And I'm like, what? Really? I didn't learn that. So as I said, if doctors are confused, what is womankind to do? My goals for the talk today are that I would like you to understand that menopause and perimenopause, it presents this massive opportunity for optimizing your health and preventing disease. It's a huge opportunity, and we don't want to miss out on that opportunity. It is also a massive opportunity for you to be taken advantage of, and taken advantage of by the wellness industry, perhaps. Even well-intending practitioners may lead you astray if they're not up to date on the science. And I mean, that was me a few years ago. What I know now, and I think back to what I would have recommended a few years ago, I didn't know. I didn't know any better. Well-intentioned, maybe leading some people astray. So we learn more, we do better. But I want you to know that there is this opportunity for people to take advantage of you because you are vulnerable. You're going to be feeling potentially really unwell at times. And I want you to feel confident that you can find your path forward and sort through what we described earlier in the I guess the marketing for this talk, sort through the snake oil and the science, and really know what's up. And some of the things that I'm talking about here are, there are all kinds of things that are being marketed to you if you're on social media. I mean, like, you can't even go on social media without having something marketed to you that pertains to potentially some of your menopause related symptoms and insecurities. And the media is having a heyday with this. Social media is having a heyday with this. We don't want people taking advantage of you or your wallet. So I want you to see the opportunity for optimizing your health and preventing disease. I also want you to, anticipate the misinformation related to an expert. Everybody knows somebody who had some terrible experience with hormone therapy, and the media sensationalizes things, right? A study gets published, the media has a heyday with it, and you don't know what to believe. Individualized treatment has never been more important. So in my line of work, I get to spend a lot of time with people. I have the luxury of really individualizing care. Not every profession has that luxury of time and resources, but in menopause care, it's never been more important. You need individualized care. And the other thing, timing is everything. Treatments can be incredibly helpful, and they can be incredibly harmful, depending on the timing. And we'll get into that more specifically as I talk through different symptoms and health concerns. And just finally, the goal for this talk is to understand that healthcare is a conversation. So I want you to feel comfortable taking up space in that conversation and advocating for yourself, because you're probably going to have to advocate for yourself. And that's not easy. And also, just because your symptoms are common or normal for your life stage, it doesn't mean you have to just like suffer with them, potentially for decades. And more on that later. But there's a lot of fear about the risks of hormone therapy. We're going to get into some of those specific risks today. But I also want you to think about what are the risks of not accessing treatment, because there are risks associated with not accessing treatment, or risks associated with using inferior or ineffective treatments. And some of those things would be like herbal medicines that I have recommended in the past. People in my profession may recommend them. You might be able to find them at the health food store. They are potentially quite ineffective, or they are not as effective. They're not going to give you the health benefits that you're looking for. They're not going to reduce your disease risk. So there is a risk associated with not treating. And before I get into the meat and potatoes, that was just the appetizer, by the way. You're probably hungry for more. I want to just let you know, quick disclaimer. The insights I'm sharing today do not constitute medical advice. I'm not treating you one-on-one. This is intended to be educational. And if you have any questions or concerns, please bring it up with your family doctor, your nurse practitioner, your naturopathic doctor. And if you need somebody to take those concerns and questions to, the back page of your the document I shared with you has some information. And if you're tuning in online on Zoom, Active Life has emailed you this document. So page 4 has some great resources if you want to dive deeper into the information, and also a way to find practitioners who are really up to date on how to prescribe hormone therapy. I'm actually not certified to do that yet. So that's like one of my goals and where I'm moving in the direction of my practice. However, I can't prescribe hormones. So the patients who I work with, I will advocate for them to have those hormones prescribed when necessary, whether it's with their family doctor or a colleague naturopathic doctor. But please take any questions or concerns to somebody. Today's information is not intended to be specific treatment advice for yourself. And one other thing I just want to mention is that not everybody who is going through menopause identifies as a woman. So although I'm using kind of gender specific terms here, I just want to know that this should be interpreted as an inclusive conversation. So some people will be going through menopause. They don't necessarily identify as female. This talk applies to you as well. And now I want to give you a quick overview of the specifics we're going to dive into deeper. How are we for time? Okay, I'm talking very quickly. What I would like to do is get through all the information. And that way, if anyone needs to leave, like right at 8 o'clock or sort of 8:15, head out, stick around and answer questions. So please raise questions till the end. I'm happy to stick around and answer them. So the overview today, menopause. What exactly is menopause? I think we all have a pretty good idea what it is. It's when your ovaries decide to retire and move to Arizona. Or Tofino, that's where I'm going to move when I retire. But specifically menopause is when you haven't had a period in 12 months at the appropriate age when you would expect to not have a period for 12 months. So if you're in your 20s and that happens, that's not necessarily menopause. Perimenopause is the period of time. It could start in your late 30s, definitely into your 40s, and it spans several years and includes that first year after your last period. So you don't know it's your last period until you've had 12 months without it. So that's perimenopause. And I work with a lot of women who tell me, oh, my doctor said I'm not in perimenopause yet. It's like, well, no, there are ways you can tell if you are or not. I won't get into the specifics of that here, but let's just say if you're in your late 30s, early 40s, it's highly likely you're starting to experience some changes that are due to perimenopause. The symptoms of perimenopause and menopause are due to this dramatic reduction in estrogen. So your ovaries, they're like, I think I'm good. I think I'm going to retire soon. They slowly stop making estrogen. But in that process of perimenopause, you have these like wild fluctuations in estrogen, which can make you feel kind of funky. We'll get into a bit of that, exactly what that means. But the massive reduction in estrogen is what is causing symptoms. When I talk about hormone therapy, I'm referring to what's called menopausal hormone therapy. So that is the correct term now for referring to using hormones to treat you in menopause. We used to call it hormone replacement therapy, or HRT. This is just a technicality, but menopausal hormone therapy just more accurately reflects what we are doing with that hormone treatment. So when I talk about hormone therapy, talking about menopausal hormone therapy, and that's specifically giving you estrogen and or progesterone in different forms to deal with symptoms and prevent disease. There are different options for hormone therapy. There are synthetic hormones and there are natural or bioidentical hormones. There is a place for both. There is a lot of research on both. More robust research in some cases on the synthetic hormones. They've been around a lot longer. But when I talk about synthetic hormones and bioidentical hormones, know that both of those are prescription products. You do need a licensed a medical doctor, nurse practitioner, naturopath to prescribe that. You can't order these things online. And then the other thing is that Health Canada approves, there are certain hormonal products that are Health Canada approved. And these are the things you really want to use. There are other hormonal products available that are custom compounded in the pharmacy, and they're very popular. A lot of people use them. And they have a place, but they don't have as much robust scientific evidence to support their efficacy or their safety. So if we're accessing hormone therapy, we really want to be turning to the Health Canada approved products. And many of those are natural bioidentical hormones, which is really cool. And the custom compounded formulas or custom compounded hormone products are not necessarily superior. There's a lot of misinformation around that, I find, even in my profession. And the science just does not support using those unless there's a really good reason. They are considered inferior. And just as an example, if you're using a custom compounded progesterone cream and you're taking estrogen, that custom compounded progesterone cream is not sufficient to protect your uterus. And that's an example of using something natural that seems like maybe that's a good idea, but you may be putting yourself at risk by not actually using something that is effective enough. So the specific symptoms and concerns and health risks that I'm going to talk about, there are 10. They're on the first page of your document there. I just want to lay that out for you so you can kind of visually see where I'm going in my brain today. And then in page 2, I gave you lots of space to make notes. So feel free to jot things down that you think, hey, I need to talk to my doctor about that, or I need to Google this when I get home, or check one of the resources on page 4. That's a really good place to get evidence-based information if you have questions. So these 10 areas I want to dive into: vaginal dryness, which we call genitourinary syndrome of menopause, hot flashes or vasomotor symptoms. I feel like I'm having one of those right now. I think it's because I was lifting heavy shit, but I don't know. Like, it could be I don't know, maybe it's a hot flash. Sleep, really important. Mood, memory, and cognition. Cardiovascular disease and diabetes, which I've lumped together. Body composition and weight, a very common concern in perimenopause. Bone health, osteoporosis, cancer, and mortality. And something that I will draw your attention to as well in the booklet that you have, page 3 has a menopause rating scale. So feel free to use this. If you want to just kind of see, like, where am I at? What kind of symptoms am I having? This is a tool that you can then like take to your practitioner and be like, I fill out this document. It's, giving me a baseline of where I'm at with respect to menopausal or perimenopausal symptoms. And it's a really great place to like start having a conversation about where you may need support. Maybe, if you are accessing treatment already, is it efficient? Is it getting you enough relief? Do you need to look at making some adjustments to your care plan? So let's talk about vaginas. Let's just get right into it and talk about vaginas. So vaginal dryness, this is a big deal. This is a really big deal. So I'm not quite there yet to be experiencing this, but I mean, God, it sounds awful. Vaginal dryness, pain with sex, that just sucks. We're going to be having another talk, part of this series, with Laura Powers, who is a physiotherapist, pelvic floor physiotherapist. She is going to get into details that relate to pelvic floor health, lower urinary tract health, and how using estrogen, applying that locally, can be really helpful. So I'm going to let her cover the details of that. That is something that's very helpful, very low risk, and recommended as a first-line treatment for certain conditions and concerns. I'm going to talk more about vaginal dryness in the context of like your sex life, because that's important. And this statistic shocked me. Less than 25% of women seek treatment for vaginal dryness or pain with intercourse. Less than 25%? But I get it, right? Because it's culturally, maybe that's just not okay. You don't talk about these things, or you're embarrassed, or maybe your partner is aging and inattentive and you just feel like, well, maybe it doesn't matter. But this affects more than just your sex life. Like, this can affect the health of your urinary tract, your pelvic floor. And the important thing to know here is that vaginal moisturizers, and people will say, oh, just use coconut oil, right? Probably heard that. It works, but not enough. Like, if you have mild vaginal dryness, maybe a little bit of coconut oil or a vaginal moisturizer will work. But if you've got like moderate to severe vaginal dryness, you need estrogen, either locally applied or systemically administered estrogen in the form of like a transdermal cream or patch. Your vagina needs estrogen. So when your vagina doesn't have estrogen, it starts to atrophy. It literally dries out. It gets like more, want to have a pleasurable sex life. So not to mention, it's just uncomfortable, even aside from sex, right? If you have a lot of vaginal dryness, like exercise is going to be uncomfortable. So the other thing I wanted to mention in that regard was that, oh yeah, moisturizer. So if you're using a vaginal moisturizer, it doesn't prevent progression of your vaginal dryness and related symptoms. You can get infection, you can get all kinds of problems that can come about as a result of this. So you really want to have it addressed. And if your only symptom is vaginal dryness or pain with intercourse, locally applied estrogen, so vaginal suppository or tablet, a ring, vaginal creams, all of these things can be really safe and really effective. So you don't necessarily need to use a systemically acting estrogen, which comes with greater risks. You can use locally applied estrogen. And that's also safe for women with breast cancer. So we'll talk a bit more about that specifically, but you can use topical locally applied estrogen to take care of your vagina. It's not going to affect the rest of your body. And libido, I want to talk about libido in the context of vulvovaginal health as well, because we often think like libido starts to tank in midlife, but it's not really something that's associated with your hormonal changes per se. It's not that your hormones don't have any impact on libido, but libido problems have a lot more to do with stress and your state of mental health and feeling tired and exhausted. But the hormonal treatment that restores vaginal lubrication also helps with just making your vagina feel like stronger and more receptive to intercourse again, or any sort of penetrative sex. Like you need estrogen to have that, to have a vagina that's not going to be in pain when you have fun. The other thing is that the application of estrogen, whether it's systemic or local, it increases blood flow and lubrication. So that has also been shown to improve sensation. So you're not necessarily going to be more aroused or have an increase in your libido by using hormones, but your sex life will be better because things will feel better and things will not hurt. So very important to know that hormone therapy is not an answer for libido. The libido needs to be addressed with other factors. So yeah, but as I think I've described that probably adequately. Yeah, we want estrogen. Your vagina wants estrogen. Oh, and one other thing. This is what I want to mention. Sorry, the when it comes to libido. Okay, so hormones are not necessarily what are the answer. Using hormone therapy is not necessarily the answer for your libido. However, testosterone that plays a role in libido. And I'm not going to get into using testosterone as a treatment, but I do want to point out that there's a really great way to increase your testosterone, and that involves lifting heavy shit. So if you're not weight training or doing things that are really using your muscles, try that out and see how that works. It's also great for stress reduction. It gets you out of fight, flight. It gets you into rest, digest. That's where your brain is more like, hey, maybe I want to have sex today, right? So exercise, great for libido. And I'm going to move on to vasomotor symptoms now. Hot flashes. I keep making jokes about them. Like, I don't know, maybe I'm having one. No, I don't think so. It's usually a lot more intense, right? Has anyone here had a hot flash before? You know what I'm talking about. Yeah. So hot flashes actually, what's that? Feel like you're going to combust. Yeah, I just have this feeling that I'm going to get them real bad because I think I already get them. But you can get that like sensation of heat for other reasons. But hot flashes, does anybody here know how long they last on average? Like, like how many years? For how many years on average women will experience them? Like, assuming you don't seek treatment. Put up your hand if you think it's 2 years. Put up your hand if you think it's 5 years. Put up your hand if you think it's 7 years. Put up your hand if you think it's 10 years. Put up your hand if you think it's 15 years. Okay, so the average, none of you are wrong, by the way, because it varies, but the average is 7.4 years. Like that's a lot of life to be having hot flashes. Oh my God. So 7.4 years, let's just call it 7.5 years, almost a decade. So if you don't seek treatment for your hot flashes, and I mean, and that's not just during the day, that's at night, you have night sweats. A hot flash at night is called a night sweat. And then you get really cold after a year. So not only is that just like really annoying and potentially super interfering with your quality of life, and like, I don't know, maybe if you're in a boardroom and you're having a hot flash, like, you know, you're in the prime of your career potentially, and all of this is going down. Not cool. So not only is this annoying, but it affects your sleep and it affects, you know, your mood. You'll be irritable if you don't sleep. You're waking up with hot flashes all night. You don't sleep. You're going to be feeling depressed potentially. And if you don't sleep, you have more like metabolic problems. Sleep deprivation increases your risk of diabetes, heart disease, and dementia. Not cool. But if you have frequent or persistent vasomotor symptoms, hot flashes or night sweats, it's associated with a 50 to 77% increased risk of heart disease in the future, as in like 50 to 77% increased risk that you are going to have a heart attack or stroke. They will go away. So hot flashes do for most women eventually go away, but some women will have them longer. Some women will have them 15 years or more. Like I think, yeah, they still have hot flashes. 7.4 years is the average that they will last. Nobody told me that when I was a kid and I was learning about my period and all this stuff. Or nobody tells you, yeah, one day you're gonna have hot flashes. They might last 7.5 years. You might want to talk to a doctor about treatments. Well, you know what? It's a good thing that we're all alive right now, because the treatments that were available 20 years ago, the HRT of our mothers and grandmothers, it wasn't as good. They weren't doing it right, but they didn't know any better. So we have a lot of really good options now. We've got good research, good data on safety, on efficacy. So I'm just like, thank God that I'm going to be going through menopause in the next like 10, 15 years, and not 10, 15 years ago or 50 years ago. That was just a nightmare. Anyway, I won't get into that. If you ever want to read about the history, yeah, some interesting stuff there. But anyway, the heart disease risk piece is huge, because you know, when we think about like what's the number one thing that kills women, we always forget that it's heart disease. Heart attacks and strokes, like that's the number one killer. So if you can do something to mitigate your heart disease risk, maybe the most important thing you do, right? So we can control vasomotor symptoms. Just gonna have a drink of water here. We can control vasomotor symptoms with hormone therapy. It is by far the most effective and the safest thing you can do. There is nothing herbal or, you know, in my naturopathic medicine toolkit, there is absolutely nothing that I've got on hormone therapy. Not that hormone therapy isn't in my toolkit, it's just not there yet because I can't prescribe it. But if we want to talk about like black cohosh, and there's herbs and stuff that supposedly help with hot flashes, and you know, some women may get a bit of benefit, but the studies do not support using them, because we have this other treatment that is so much more effective at not only effective at regulating your symptoms, but effective at preventing disease risk. So that's the big part, the heart disease risk. So if you access hormone therapy for your hot flashes, it reduces the frequency by 75%. It reduces the severity. There's a dose response relationship. So the higher the dose of your estrogen therapy, the better relief you get from your hot flashes. You see improvements in about 4 weeks or less. That's pretty cool. And the other thing is that, I forgot to mention, hot flashes, your vasomotor symptoms, not only are they associated with this massively increased risk of heart disease, but also massively increased risk of high blood pressure in general, insulin resistance and diabetes, high cholesterol, faster heart rate, more inflammation, more clotting, a good thing. And when we use hormone therapy to treat your vasomotor symptoms, we are actually reducing your risk of getting heart disease. But timing matters here. And I'm going to talk about that a little bit later. We're going to come back to heart disease specifically. Vasomotor symptoms, just one other quick tidbit here. Lifestyle modifications, there are some. They can give you a bit of relief. Antidepressants have become like the kind of go-to that we prescribe women for hot flashes. And that's because there's been a lot of fear around hormone therapy. And as a result, we turn to antidepressants because they are effective, they do help, but hormone therapy is superior. And the guidelines, the clinical guidelines, based on all the latest research, say you should access hormone therapy first. Not to say you can't also use an antidepressant if it's indicated, but you should be looking for hormone therapy first. Sleep, I want to talk about sleep now. So 40 to 60% of women experience sleep disturbances in menopause. Not a big surprise. I would think the number might be even higher than that. So menopausal hormone therapy helps with sleep, independently of it helping with your hot flashes and night sweats. So it's not just about the hot flashes and night sweats waking you up. There are other things going on that are messing with your sleep. And hormone therapy helps a great deal with this. And you need to, in this case, use estrogen and progesterone. Progesterone needs to be used orally, and progesterone is actually a sedative, a mild sedative. So using your progesterone at night is typically what's recommended, and that helps you fall asleep and stay asleep very nicely. You need to use it for like 6 months or more, so it's not a quick fix. Your hot flashes, they'll get better faster. You might need your hormones on board for about 6 months before you see that like sustained improvement in your sleep. So, if you start taking it in 3 months and you're like, this isn't helping, this is where it's important to know that some of these things take a lot longer to take effect. And sleep is extremely important. I think I mentioned earlier, if you're not sleeping enough, it significantly increases your risk of heart disease, diabetes, dementia. It does. And you need 8.5 hours of sleep per 24-hour period. So I always hear people, seniors especially, saying, oh, I don't really need that much sleep anymore. It's like, actually you do. The studies show the optimal amount of sleep for men and women, 50 plus, you need 8.5 hours of sleep per night. Yeah. And if my husband was here, he'd be laughing in my face because I am such a night owl and I don't sleep nearly enough. But this is scaring me into want to work on my sleep routine. The risk of not sleeping, as I said, heart disease, #1 killer, diabetes, dementia, not cool. So hormone therapy helping you with your sleep. There are other things that can also help with your sleep. Exercise being a great one. And of course, there's a lot more beyond the scope of this talk. I want to talk about mood. How are we for time? Okay, not too bad. I'm going to power through the next bit. I'll try not to speak too quickly. Mood. Your mood matters so much. As I always tell my patients, your mood is driving the bus. If you're having a hard time taking care of yourself and making healthy decisions, a lot of the time it's because your mood is like, it's not okay. You're struggling. So we really need to support mood. And this really shocked me. There is a window of vulnerability in and around your menopause when you have a 14 times greater risk of developing depression. 14 times greater risk. It's horrible. So this is in that 2-year window, this window of vulnerability around when you're having your last period. And again, you don't know it's your last period until you haven't had one for 12 months. So depression, anxiety, stress, emotional distress, all of these things really start to peak in that late perimenopause. And you're literally on a roller coaster. Your hormones are going all wonky, right? And it's normal. There's nothing wrong with that. It's supposed to happen. But your brain does not feel okay when your hormones are going wonky. So it's important to know that when you're starting to experience mood changes, it's really common. Most of us will experience it. There is support for you. It doesn't necessarily mean you go on an antidepressant. Antidepressants are wonderful, however, and they can be really helpful. But if your mood symptoms are primarily related to your menopause transition, your perimenopause or menopause, you really want to be looking at hormone therapy. That is what the research supports. That is what the clinical guidelines support. Page 4 of your document. Again, if you want to look into that further and read the recommendations, I've given you links. If you want to nerd out on all the details, which I highly recommend, we want to be looking at hormone therapy to regulate your mood. At the same time, it's going to help you with your sleep, your vasomotor symptoms, all the things. And importantly, just a few tidbits here. If you've had a hysterectomy, maybe you've needed a hysterectomy for whatever reason, this actually significantly increases your risk of developing depression in and around your menopause, especially if your ovaries have also been removed. But even if you've had a partial hysterectomy, you still have your ovaries, you just had your uterus removed, you actually should access hormone therapy. And the timing matters here. We want to do, I forget the specifics on that, but I think it's like before the age of 50. You want to access hormone therapy to support your mood and reduce the risk of experiencing depression. And post-menopause, so let's just say you don't access hormones for your mood, you go through menopause and you're like 10 years post-menopause. If you access hormone therapy at that point in time, it does not help with your mood. It may help other things, it doesn't help with your mood. And you'll see in a few moments, there are actually a lot of reasons why you don't want to start hormone therapy more than 10 years beyond your menopause, because it increases a lot of risks. And I think that's all I want to say about mood. But, oh yeah, one other thing, if you have had any history of mental health concerns, anxiety, depression throughout your lifetime, whether or not it was related to hormones, you're at a greater risk of experiencing a relapse in those mood symptoms. So just keep that in mind and seek support for your mood, and know that hormones can actually play a really important role there. And while we're talking about your brain, I want to talk about memory, cognitive function. So it's kind of a joke, right? In perimenopause, you're like, I walked into the room and I'm like, I don't know, why did I come into this room? Has anyone done that? Yeah. I do it, but I blame COVID because I have long COVID. I'm getting better finally, thank you. Yeah, memory and problems, cognitive problems. Now, when this is happening in perimenopause, you're thinking, oh my God, what's going on with my brain? Am I developing dementia or Alzheimer's? No, this is not associated with that. Like most of the time, it's not. So these cognitive changes tend to be transient. They're not an indicator that you are going to develop Alzheimer's or dementia. And they're not just related to sleep problems. So even if your sleep is like dialed right in, you might still have some memory problems. So just know it will eventually better your brain. It's just like here on things like nutrition, exercise. Exercise makes your brain work better. I think that's why I'm feeling really sharp right now, because I'm just lifting stuff. Exercise is great for your brain. There's one exception here with respect to hormone therapy, cognitive changes in menopause, where we really do see a huge increased risk of cognitive decline that could actually lead to Alzheimer's and dementia. And that is if you've had a surgical menopause. So you've had a complete hysterectomy, ovaries, they're gone. For whatever reason, it doesn't matter, it had to happen. If you have a surgical menopause, especially if it's like before the age of 46, like you're fairly young when this happens, it increases your risk of dementia by 70%. Like they should like put that like a label warning on, like we should know that. Shouldn't we know that? I think we should. I don't know, maybe they tell you this when you need to have a hysterectomy. I'm hopeful that that's common knowledge, but menopausal hormone therapy is really important, right? Especially if you go through a surgical menopause in your early 40s, you need to have hormones replaced to protect your health. And if you do access menopausal hormone therapy in that situation, you actually have a 50% reduced risk of developing dementia. So big deal, great place for menopausal hormone therapy. Now, menopausal hormone therapy, if you are looking to access that later in life, like 10 years or more after you've gone through menopause, it actually has it's associated with a significantly increased risk of developing dementia. So again, timing is everything. It can be really helpful at one life stage. 10 years later, the opposite. So you really want to have a good informed conversation, a shared decision-making conversation with your prescribing practitioner to understand, is this going to help you or is this going to harm you? Yeah, so like if you start hormone therapy after 65, you have a double the risk of developing dementia. And however, you can use vaginal estrogen. So if you're 65 plus, maybe you've been single for a while and you meet a new man or a woman or a person, you want to have a good sex life. You're like, maybe I should get some vaginal estrogen. You can do it. It's not going to give you dementia. You can't use systemic estrogen, but you can use vaginal estrogen. So that's good to know. And I want to talk now about cardiometabolic health, cardiovascular disease, heart attacks and stroke, diabetes. And I'm going to talk about body composition at the same time because they really go together. So they're two separate little blocks on that first page of notes I gave you today. So cardiovascular disease, again, I just want to stress heart attacks and strokes are the number one killer for women. It's not just men who have heart attacks and strokes. And your risk for having a heart attack or stroke increases when you go through menopause. And this is because your hormonal changes cause what I would like to call a redistribution of assets. Redistribution of assets. So what is premenopause? Subcutaneous fat that gives you some curves of different shapes and sizes. That adipose tissue, which is completely safe, moves here. It goes inside your abdomen, under your abs. So it's not like you can pinch it. It's like underneath your abs, hanging out with your organs. There's a small amount of space there, and we can only store so much fat there. It's okay to store a bit of fat there. We all need it. But if we are storing excessive amounts of adipose tissue in that visceral cavity, abdominal fat, belly fat, that fat actually starts to spill out inflammatory chemicals into your blood, things called cytokines. The same things that make COVID really bad. You have a cytokine storm. These inflammatory chemicals are released by visceral fat. They go into your bloodstream. They affect your blood vessel health. They also affect your brain health and all your organs. It's just not a good thing. They make your joints achy. Visceral adipose is something that we start to accumulate as we go through menopause because of hormonal changes. So it's actually perfectly normal when you go through menopause that you may become a little rounder in the midsection. It's normal. We can't really stop that from happening. Even if we're really physically fit and exercising, there will still be this redistribution of assets. And the hormonal shifts are responsible for this. So before menopause, you have estrogen, keeping that adipose tissue out of your viscera. Post-menopause, the estrogen drops off. There's nothing preventing that fat from accumulating in the visceral cavity. So the cool thing is menopausal hormone therapy. Guess what? It helps with this. It's not like a miracle or anything. It doesn't prevent you from gaining belly fat, but it slows down the accumulation of visceral adipose, which is pretty cool. Because this isn't just about vanity. This is about your health. This is about your cardiovascular health, your metabolic health, preventing diabetes, preventing heart attacks and strokes. And yeah, so that when men gain weight, they get belly fat, right? The typical what we call the beer belly on a man. When we're post-menopause, our hormonal changes allow us to gain weight in the same way. We then have the same risk of heart disease as men, essentially. So when you use oh, yes? How do you know when you're gaining too much? Good question. So there are actually, I forget the exact number, I could look it up, but there are waist measurements that correlate with a greater risk of heart disease and lower risk of heart disease. And I think if I'm not mistaken, I think it's a 30-inch, and this is at the thinnest part of a person's waist. I think it's a 30-inch circumference or less, or is it 35? 30 to 35 for women. And then for men, I believe it's 30 for women and 35 for men, but I could be wrong. It could be 35 and 40. And so depending on your height. Exactly. Yeah. So if you're 5 foot tall versus 6 foot tall, then it would be okay to have more. But that measurement at the circumference of your waist, at the thinnest part, kind of around your belly button, there is a range that we know it signifies that you actually have more visceral fat than is appropriate for your health. So, and that is indicating there's fat accumulating in your liver and other organs that will lead to those organs becoming compromised over time, right? If we talk about non-alcoholic fatty liver disease, this is when adipose tissue accumulates in your liver. Over time, it interferes with your liver's function, part of which is regulating your blood sugar. Diabetes can happen as a result of that. So measuring your waist circumference, and I'll clarify what those numbers are. If anyone knows the answer, no. Yeah. Waist ratio. I think when it showed that just the circumference of the waist was enough, that was a good indicator of cardiovascular risk. But waist to hip ratio is another one, and I've certainly heard of that one, and I forget the exact number for that. But another really good indicator of your cardiovascular fitness and risk is actually your grip strength. So grip strength, so if you can like hold on to heavy stuff, like when I try to lift up my skillet at home and I'm like, oh my God, that's so heavy because I haven't been lifting heavy shit at the gym enough. That's an indicator my cardiovascular health is declining because it means I'm made up of less muscle. If you're made up of more muscle, you have better metabolic health, which is why we want to lift heavy shit. And come to Jess's talk to learn about the nutritional aspect of that to make sure you're able to fuel the muscles you're trying to grow by lifting the things. Did I answer your question about that? Okay, great. Yes, I think I just want to repeat this here. I didn't say it already. Menopausal hormone therapy reduces your risk. No, I didn't say this yet. Diabetes. If you use menopausal hormone therapy, it reduces your risk of developing diabetes by 30%. 30%, that's a big deal. Estrogen also does not cause weight gain. So there's a big misconception that estrogen causes weight gain. It doesn't cause weight gain. Studies have found that this absolutely does not correlate with weight gain. If anything, estrogen has been shown in studies to slow down the accumulation of visceral adipose. So it helps to keep your assets more in that, maybe where you would prefer to have them for aesthetic reasons, instead of everything kind of moving and shifting into the visceral cavity. So moving from that kind of more hourglass or pear-shaped body into more of an apple-shaped body. Estrogen helps to mitigate some of that, not 100%. It's normal for your body to change. It's okay for your body to change. We just want to keep your body strong and disease-proof you as much as possible. So menopausal hormone therapy can play a role here as well. And this is another really cool thing. If you access menopausal hormone therapy, you're using estrogen, you're using progesterone, it actually improves your blood sugar regulation, even if you don't have diabetes. So if you're one of those people who gets your blood work done and your doctor's like, you're fine, everything looks good, you're not diabetic, you're not pre-diabetic either. Your blood sugar level is within normal limits. So like your fasting blood sugar is below 6. You will still have an improvement in your blood sugar and your insulin level when you use hormone therapy, even if you fall into that normal range. And that's important because that so-called normal range is not the optimal range. So when I do blood work for my patients, I always show them that, like, yes, your blood sugar, your fasting blood sugar, it's in the so-called normal range, but it's actually higher than what we know is optimal. The reference ranges on lab reports are not always an indication of what is optimal. Some of them are just an indication of what is common and normal in the population using that particular lab, or they haven't really been updated in a while to reflect what is optimal. So that's not to say that everybody needs menopausal hormone therapy to improve their blood sugar, but having individualized care, having a look at what's going on with you metabolically, with your blood sugar, what's your fasting insulin look like, that might be a good justification to use menopausal hormone therapy, especially if you have other symptoms that need to be dealt with. And I think I mentioned this here that hormone therapy, especially estrogen, reduces your risk of cardiovascular disease. But again, you need to use it before the age of 60. If you have early atherosclerosis, so you're starting to develop those cholesterol deposits and plaques inside your arteries, which is something that happens as we get older, the early atherosclerosis, early changes that are happening in the arteries that will happen in your 40s and 50s, when you start using estrogen, when you start using menopausal hormone therapy, it actually starts to reverse that to a certain extent, attack and stroke, by using hormones. But if you have established atherosclerosis, you're 60 plus, you've got some plaques building up inside your arteries, menopausal hormone therapy will actually destabilize those plaques and increase your risk for having a heart attack or stroke quite substantially. So again, timing is super important here. If you're younger than 60 or older than 60, it's a really important conversation to have there about your risk benefit situation. And using estrogen orally has an impact on blood clotting. So I'm a big fan of people using estrogen transdermally, which in the form of a Health Canada approved gel or patch. That does not affect your blood clotting. It does not make your blood more clotty. So, when you take the birth control pill, it has this increased risk of causing strokes and blood clots. That's because estrogen, when you take it orally, your liver, it interacts with your liver in such a way that it affects your blood clotting. It makes your blood more sticky. So when you use estrogen transdermally, you completely avoid that situation. So also a good thing if you have an increased risk for heart disease for any reason. And I think that's all I wanted to say about heart disease. Any questions specific to heart disease while I'm on that topic? Because I think it's a really important one that doesn't get a lot of attention with women's health. Oh, okay. So bone health. I know Sarah knows a lot about bone health, so she may want to chime in here, but osteoporosis. Also, it's not like a really sexy topic, but it's a really important topic because 1 in 4 women who have an osteoporotic hip fracture will die within a year. It sucks. So we probably all know someone who that has happened to. 1 in 4 women who have had a hip fracture will die in the first year post fracture. Did you know that? That's crazy. I had to check that. I had to look it up. And this is also pretty crazy. When you go through menopause, the first 5 to 7 years post menopause, you lose 20% of your bone density. 20% of your bones, like they just dissolve. And of that calcium from your bones, guess where it ends up? In your other assets. That's right, in your cardiovascular system. So in your blood vessels, when your blood vessels start to get like plaques forming in them, part of what makes those dangerous is that they become calcified. So calcium in your body, so you've heard that analogy of like a garden hose, that really old garden hose that's all stiff and it can crack and break open. Similar kind of situation. Calcium starts to make your blood vessels stiff, not elastic. That means your blood pressure gets higher. You're at a greater risk of having a heart attack or stroke. So not cool. Bone health and heart health are kind of linked in that way. And of course, menopausal hormone therapy saves the day again, associated with a 30% decreased risk in fractures, regardless of anything else. So independently of, like, it doesn't matter if you exercise, if you supplement calcium or vitamin D, it doesn't matter if you have a family history of osteoporosis, like we can just basically apply that to anybody. You get a 30% reduced risk of fracture, regardless of the things you're doing in your life to try and keep your bones healthy. So that's a really big deal. And there's nothing that we have nothing that we have in the way of natural medicines that do that. Not to say hormones aren't natural. A lot of the hormones that we would be using are actually natural substances. They're just Health Canada approved drugs. So yeah, menopausal hormone therapy can also increase your bone mineral density by 4% in 3 years. This will dissipate quickly if you stop. So if you stop hormone therapy, your bone density, it does start to drop, but you don't have a rebound fracture risk. So I didn't mention that with respect to cardiovascular disease. If you stop menopausal hormone therapy before you're 60, in the first year, there's an increased risk that you might have a cardiovascular event. You're better off to wait until 60 plus. When it comes to bone health, you can just stop, it's fine. You're not going to have a rebound risk. You just start to have the same risk you would have had anyway if you weren't taking hormone therapy. And any questions about bone? I think we're doing actually fairly well for time here. So I want to talk about cancer and mortality, and then I'll wrap things up and open up the floor for questions. Okay, so let's talk about cancer. Nobody wants to talk about cancer, but it's important. And it's a big question when we talk about menopausal hormone therapy. It's a reason why a lot of women say, oh, hell no, I'm not doing that, because I know somebody who got breast cancer, right? Or I have a family history of breast cancer, so I'm not going to use hormone therapy. And I would encourage you to have a good conversation with your provider about what is the actual risk for you and what is the benefit and what is the risk of not accessing hormone therapy when you would actually benefit from that in other ways. Breast cancer risk, it's real. Hormone therapy does increase your breast cancer risk. It does. We know this, but we also know how much. And I was scouring over the numbers on this so that I could feel very confident in telling you, this is what we know now. And this might change, like all of what I'm sharing with you now, 5 years from now, it might be different. We'll have new research. We might have to change our tune a bit. But right now, what we know from very large studies is that when you use menopausal hormone therapy, the increased risk that you experience with respect to breast cancer is equivalent to 1 woman out of 1,000 women. So 1 in 1,000 women will get breast cancer per year because of menopausal hormone therapy. 1 in 1,000. So you've got to think about what 1 in 1,000. Let's put that into context, because context is important. This is a lower risk than drinking alcohol. So if anyone here drinks, I don't know, 2 glasses of wine in a day, often. I am not lately because I'm doing dry January, which is awesome, by the way. But a lot of women will drink alcohol, and it's not uncommon to drink 2 drinks per evening. That is associated with a far greater risk for breast cancer than hormone therapy, far greater risk. And also a sedentary lifestyle. So if you're not exercising, if you're not like getting some movement and exercise for like 2.5 hours per week, not per day, don't worry, oh my gosh. Well, maybe some of you do that. Good for you if you do, but 2.5 hours of moderate intensity exercise per week substantially reduces your breast cancer risk. But if you've been kind of hanging out on your sofa a lot, like I have the last 6 months, as I've been recovering from long COVID, that type of sedentary behavior is associated with a far greater risk for breast cancer than if I were to opt for hormone therapy. If I needed that hormone therapy to control symptoms and manage my risk factors. Again, individualized care, timing is everything. So I hope that clarifies the breast cancer piece. It's there is a risk. A few things specific to this that I can just anticipate questions. The form of hormone therapy matters. Well, first I should tell you that the risk for breast cancer decreases when you stop hormone therapy. So if you're using hormone therapy and then you get to a point where you're like, I'm good, I don't need to use this anymore, you stop, your breast cancer risk just that goes away. That slightly increased risk is gone. And then the form of your hormones matters. So it appears that it's actually progesterone that is associated with this increased risk of breast cancer. And that it is with synthetic forms of progesterone. So if you're using progesterone as part of your hormone replacement or menopausal hormone therapy, using oral micronized progesterone, which is a bioidentical natural Health Canada approved drug, that's the kind you want to use. It appears to be associated with a lower risk of breast cancer. The reason why the breast cancer risk increases with hormonal therapy is because your breast density, not like your breasts don't feel more dense, but your breast density on mammography. So when we look at a mammogram and that's being interpreted, there is something called mammographic density. So your breast tissue just looks denser, more dense. I don't know how to say that. And it's harder to see, abnormalities. So women who develop that increase in mammographic breast density, they might need to have more frequent mammograms. They might have to have more frequent biopsies. That is what we think is causing that increase, again, slight increased risk in breast cancer. The form of progesterone matters. So it appears that the form of progesterone I mentioned, oral micronized progesterone, that has a better safety profile. Dose matters. Of course, we want to use the lowest dose that addresses your symptoms and manages your risk factors. Using estrogen and progesterone for less than 5 years, according to a lot of studies, does not increase your breast cancer risk. It's when it's beyond 5 years. And again, it's a very small increased risk. And we also have to, consider those other risk factors. Are you drinking? How much are you drinking? Are you exercising? And also body mass, visceral adiposity also seems to be associated with greater risk for breast cancer. And we if somebody is a breast cancer survivor, that's, there are people, we have studied this. It's hard to study hormone therapy in women who have had breast cancer for ethical reasons. We don't want to give you a recurrence, but observational studies have been performed. So we're not taking women and saying, oh, hey, you had breast cancer, here's some hormones, let's see what happens. It's women who opted to have those hormones prescribed. because they needed them for controlling their menopausal symptoms or for managing other risk factors. And so scientists have looked to see, well, what happens to those women? And it appears that with breast cancer survivors, that menopausal hormone therapy does not seem to increase the risk of recurrence. So that's really cool. Now, if a person was really sketched out about accessing hormone therapy for that purpose, but they had vaginal symptoms, you can use, again, vaginal estrogen. It doesn't affect the rest of your body in a way that would have any risk, impose any risk for breast cancer. Endometrial cancer. Oh, we've got a question. Yes. Oh, yes. Yeah, read my mind. So there are two types of cancers I want to talk about. There is actually another one. I think it's non-small cell lung cancer. There is, I think, a slight increased risk of that. I didn't bring the specific details with me, but there is a slight increased risk of that particular type of lung cancer. I would need to check the data on that. So the other two types of cancer I want to talk about are endometrial cancer and colon cancer. And let's talk about colon cancer first. So colon cancer, you might think, what do hormones have to do with my colon? Well, actually a lot. Studies have shown that hormone therapy reduces your risk of colon cancer by 25%. Cool. There are other things that can reduce your risk of colon cancer, like eating a high fiber diet and lots of vegetables and exercising and not drinking a lot and not smoking. Menopausal hormone therapy reduces that risk by 25%. And even if you still get colon cancer, it reduces your risk of dying from it by 30%. So if you have a family history of colon cancer, or you've been diagnosed with colon cancer, or you've had some atypical cells on colonoscopy, it's something, again, talk to your family doctor or specialist or oncologist about that. It might be an opportunity to use hormone therapy for one of these really nice side benefits. And now endometrial cancer or uterine cancer, right? So your endometrium is the lining that's shedding when you're having your period. If you are accessing menopausal hormone therapy, if you're using estrogen, aside from locally applied estrogen, like vaginal estrogen, if you're using anything that is increasing your systemic level of estrogen, you absolutely need to use progesterone to protect the lining of your uterus. If you've had a hysterectomy, you don't have to worry about that. You don't have to use progesterone in that case. You can for other reasons, but if you have an intact uterus and you use estrogen systemically, you need to use progesterone at the same time to protect the lining of your uterus. The reason why a lot of the Women's Health Initiative was stopped prematurely was that we started to see this huge increased risk in endometrial cancer. I think it was that study, unless it was an earlier one. Hormone replacement therapy, the old school HRT, the HRT of our mothers or our grandmothers, they didn't use progesterone, they just gave women estrogen. And that led to a significant increase in endometrial cancer, which is really sad, really unfortunate. We know better now. We have ways of preventing that, which is using oral micronized progesterone. Again, transdermal custom compounded progesterone, not good enough. Studies show it does not produce a reliably elevated blood level to protect your endometrial tissue that would potentially leave you vulnerable to cancer. So again, you want to make sure you're using that progesterone in the appropriate form, appropriate dose to protect your endometrium. And then just a quick note about mortality. We all want to live forever. Some people think we might be able to, but I think we're a few years away from that kind of technology. So at this point in time, what we can strive for is living as long as possible in as good of a state of health as possible, quality of life. But menopausal hormone therapy has a role just with extending your life. It reduces your risk of dying from any cause by 35%. Like, I'm definitely getting hormone replacement therapy here, menopausal hormone therapy, 35% reduction in all cause mortality, regardless of why you're using it or how you're using that. And that, again, needs to be started within 10 years of your menopause. You can't wait until you're 60 plus. You can't wait until you're 10 years post-menopause. And avoiding estrogen, avoiding menopausal hormone therapy is associated with an increased risk of premature death. There are good reasons to access this therapy. You need to talk to your provider to understand what's the most appropriate form for you. but it is associated with an increased risk of premature death. If anybody needs to leave, I'm going to be wrapping up in just like 3 minutes, and then we could do questions. But if you need to leave right on time, thank you so much for coming. Bye, Lula. And so in conclusion, I'm turning 40 in 2 weeks. It's crazy. So yeah, 2 weeks turning 40. It's a little surreal. It's this very important milestone birthday. It always felt like it was very far away. I felt like, you know, wasn't I 26 or 29 just like a few years ago? No, okay. So so I was like reflecting on this as I was putting this together at that. Does turning 40 mean that I'm going to be over the hill? Nobody likes this. I certainly feel a shift in myself. I feel like this is an age where I'm starting to step into my power. I'm starting to really feel the sense of I have arrived. I know who I am. I know what matters. I know what I want. I know what I have. I value myself, and I know what I have to offer the world. And I feel like this is a time where we can really lean into taking care of ourselves, like really deeply taking care of ourselves as women. So as I find myself speeding towards this new decade, I feel excited. I feel really excited, but not in the like look ma no hands way of my 20s and 30s. I feel excited in the sense of, you know, what did I want to say to you guys? I have my hands firmly gripping the handlebars as I pedal up the proverbial hill that I am about to be over. And the more I learn about menopause, perimenopause, the less I'm afraid of this being a white knuckle ride, like it has been for so many women who have come before us. And that downhill ride might be a lot of fun. I've always actually wanted to try downhill mountain biking. So maybe this is my opportunity. Just like riding down a hill on a mountain bike or skiing down a mountain in fresh powder, a mountain you've never skied on before, you need a really good guide. You need the right gear. You're a skier, you know what I'm talking about. Yeah. The right guide and the right gear, it helps to take away the fear, keeps you safe, and makes it epic. So I just want to leave you with these thoughts. I want you to eat well, get enough sleep, heavy shit, and your body will take care of the rest. Thank you very much. Thank you guys at home too. Does anybody have any questions? We're such a wonderful audience. If you've got to get going, feel free to just head out. I'm happy to stick around and answer any questions you have. Yeah, Nancy. Yeah. Yes. It depends. Within 10 years, ideally.
Sorry, Aranka, can you
60.
repeat the question? We can't hear the question at home.
Oh, of course. I'm going to repeat the question. Yeah, for sure. Thank you. The question was, if you are to access menopausal hormone therapy, does it have to be within 10 years of your menopause? So my answer to that is that it really depends. It depends on risk factors. And so there are different tools that your practitioner can use to look at, like, what is your fracture risk? What is your cancer risk? What is your cardiovascular disease risk? And what are the symptoms you're having? And so based on information, we can say, well, these are the potential risk factors. And so for, like, let's just say cardiovascular risk factors, we might be really apprehensive about giving her hormones, a younger woman, the women who have gone through menopause early perhaps, or have had a surgically induced menopause, or you just go through menopause early, sometimes it happens. You may still be able to access hormone therapy. Those women may still be able to access it. It really depends on your individual risk factors. So again, if you're in great cardiovascular shape, no diabetes, no heart disease, no like significant family history of heart disease, it might be a really good option still. And again, it depends on the symptoms you're having, the benefits we anticipate you obtaining from that. And it really comes down to what we call a shared decision-making conversation, so that you feel like you're part of that decision, that you're okay with the risks or you're not okay with the risks. But we want always to know that those benefits are outweighing those risks unique to the individual. Welcome. Any other questions? Oh, yes, Renee.
So when they say,
Right. Yeah.
it's true, but I'm still getting all the
Yeah.
information,
Mhm.
flashes and stuff like that. So
Yeah, I'm so glad you asked. It's a really good question. So there are other options. There are other drugs that are things called selective estrogen receptor modulators, or SERMs. Tibolone or Tibolone, I don't know how to pronounce that, is one. I can't remember the name of the other one I wanted to talk to you guys about. But these are drugs that modify estrogen receptors. So the estrogen receptors are these little things sticking out of your cells that bind to estrogen. And if they bind to estrogen, estrogen then makes those cells do things or proliferate, like growing more endometriomas, for example, or growing a cancer cell, stimulating the growth of the cancer cell, or stimulating the proliferation of your endometrial lining. So the receptors are these little things outside your cells that will bind to estrogen, or to drugs that are designed to bind to those receptors and modulate them. And so some of the estrogen, the SERMs, selective estrogen receptor modulators, can actually do a wonderful job dealing with some of your symptoms, perimenopausal or menopausal symptoms, while also mitigating some risk factors. So they can actually block the estrogen receptor on certain types of cells. So this is really good for breast cancer, actually. SERMs are often used in the treatment of breast cancer, or managing women post-breast cancer, to block the estrogen receptors on certain cell types so that we don't stimulate cancer cells to grow, but we do stimulate other cells to do their thing, like the cells that we want to have doing their thing so we feel good. So there are some options in that regard. SERMs are probably a good place to look. And then and using hormone therapy, again, looking at individual risk profile to see estrogen stimulate the growth of endometrioma. Conversation about your individual risk factors, what you're hoping to gain from it, what specific symptoms are you having related to perimenopause, menopause, to see what treatment would make the most sense. So it's not a hard and fast no, it's not a complete contraindication to access menopausal therapy. If you had a question, and then I'm going to make sure we ask people at home if they have questions too.
but I'm just wondering what is the opposite of the 10 years post is the
Yeah.
pre.
The pre,
And
yeah.
at what point is, I guess, how many symptoms do we want to kind of suffer with before we kind of consider this as an option?
So, yeah.
How far into therapy do we need to be? Is there like a recommendation on all of that?
I'm really glad you asked. I wanted to talk about that specifically.
Sorry, what's the question?
Yeah. So the question here, and sorry, I don't think I repeated the last question, did I? About
Oh,
Did you put it in the chat, Sarah? Thank you. Sorry about that. So the previous question was related to endometriosis, and could a woman who has a history of endometriosis use hormone therapy? And so I talked about the SERMs being an option for them, and about possibly accessing hormone therapy for that. And this question was about when you're in perimenopause, or maybe you're in your 40s, you're starting, maybe even late 30s, you're starting to get symptoms. When can you start accessing hormone therapy? Like, when is there a clinical guideline for this? And yes, there is. And it really comes down to if you are dealing with symptoms that are related to perimenopause, they are hormone related symptoms, and they're affecting your quality of life, to decide you shouldn't be denied treatment. Your age or something very clear. There's actually a great deal of benefit to access hormone therapy in perimenopause before you get to that last period. That's where we see a lot of the preventative effects of hormone therapy. Yeah. You want to get on. Yeah, absolutely. And again, like it comes down to the specific symptoms you're having, and if they are new related to this life stage, are they a relapse of symptoms you've had in the past? Because that needs to be part of the conversation too. We see this a lot with mental health, right? If you suffer from anxiety or depression, and that's kind of like always been part of your life, I mean, it's going to get worse in perimenopause, but it doesn't necessarily mean that hormones are the be all and end all for you. You might also need to do other things like exercise or take medication, antidepressant, for example, or there are certain nutritional supplements that can be great for mental health as well. But we certainly don't want to say, no, you can't have hormone therapy. You're not, things aren't bad enough yet. You're really the one that gets to decide. Context of having the discussion about, well, what would be the risk? What would be the risk? And there are different ways to use hormone therapy. I should add that in here, that when you're still having a period, and periods can get a little wonky in perimenopause. We didn't chat about that. That's a thing. Your period starts to get wonky in perimenopause. It's normal. It sucks, but it's normal. And it's not like you're doing anything wrong when that starts to happen. But if you're having irregular periods or really heavy periods, that's a thing too. When you're perimenopausal, you're not ovulating every cycle. If you don't ovulate, you don't make progesterone. If you don't make progesterone, your uterine lining is unstable and you have heavier and heavier periods. And then you become iron deficient and exhausted and depressed. Unless you see me and I make sure that like never happens. But a lot of women are in that kind of situation, right? You're having these crazy heavy periods, they're super irregular, you don't know what to do. So perimenopause, again, it comes down to what are the symptoms you're having and do hormones make sense? You can use hormones in a cyclical manner when you're still having periods. You're not just taking hormones constantly all the time like you would be post-menopause. You can cycle them with your menstrual cycle and then start to transition to a continuous dosing regimen, which is what we do kind of in and around your actual last period. There's another, oh, yes.
Alongside the hormone therapy, just some of the best tools that we have to remove some of the symptoms, these states, or in terms of your hormone.
So symptoms or treatments aside from using hormone therapy. Lifestyle tools. So I would say number one is exercise. Actually, no. I know I'm in a gym, I should say exercise, but I'm going to say sleep. Sleep. So sleep, I know sleep itself isn't a tool, but if you're not sleeping, we don't always have to go straight to hormone therapy to get you sleeping if you're in perimenopause or menopause, but helping people to sleep. And that also ties into exercise. So there are some very important lifestyle factors here. Getting enough sleep, avoiding the bedtime, revenge bedtime procrastination, scrolling on your phone late into the evening. That's what I do. We want to try to get that 8.5 hours of sleep. Exercising regularly, getting that at least 2.5 hours of exercise per week will help you sleep better. Will elevate your mood as well. Will make sure that you have better cardiovascular health. So I would say things that help you sleep, exercise being one of them. Melatonin. I'm a big fan of melatonin. The studies on that are great, especially for people 50 plus. Melatonin can be used to help you sleep, but you need to dose it properly. You need I'm not going to go into specifics because that's kind of more like giving you specific medical advice, but just knowing that accessing melatonin, taking it earlier in the evening, and then helping you fall asleep at a reasonable hour, getting a good solid sleep really helps to regulate hormones and mental health and mood. And things that I like to use are adaptogen herbs. I'm a big fan of ashwagandha and lavender and other nutraceuticals like L-theanine, even fish oil, herbs to help either support your mental health and your stress response, vasomotor symptoms, hot flashes, sleep problems. Stress makes everything worse. So I will use a lot of adaptogens or I shouldn't say a lot. I will use specific adaptogenic herbs and or nutraceuticals to help to support people who are feeling really stressed. Because as we know from the literature, we are at a greater risk of feeling more stressed, feeling more anxious, feeling more burnt out in this critical window of time leading up to menopause. And there are herbs that may help with hot flashes. Black cohosh is one of them. The guidelines that you can look at them if you want in detail on the links that I have on page 4. Some of those links actually go into detail, or I should say the links will take you to clinical practice guidelines that touch upon things like herbs that will say that, you know what, black cohosh, it might help you, but it might not help you enough. And the risk there is that if we're not giving you an effective treatment and you continue to have the symptoms, we're not actually mitigating the associated risks. Like if you're taking black cohosh, you're still having symptoms of hot flashes, that's not good for your cardiovascular risk profile. So I steer away from those herbs, unless symptoms are very mild. If we're looking at moderate or severe symptoms, I really am encouraging people to access hormone therapy. And I just want to make sure I'm not missing anything in that regard. So with respect to just symptom specific, of course, with bone health, we need vitamin D. We should get that level tested in some cases. Not everyone needs it tested, but some people are at a greater risk for deficiency, should have their vitamin D tested and make sure they're actually treating or supplementing to reach the target of an optimal level. Calcium through diet, ideally. Supplementation does come with some risks. So we ideally want to be getting calcium through diet. And that actually brings up another thing related to perimenopausal symptoms, which is PMS. A lot of women get like an exacerbation of their PMS. PMS gets a lot worse as you go through perimenopause. Calcium is actually one of the best treatments. As far as, actually it is the best treatment. If it is not, strong enough to deal with the intensity of a woman's PMS, if her symptoms are more bordering on like the PMDD, a more severe PMS that's really qualifies as a mental health diagnosis, we may be wanting to look at something like fluoxetine, which has a very good safety profile and is very effective for treating PMDD, premenstrual dysphoric disorder. But PMS, the milder version of PMDD, so PMS responds really well to calcium. A lot of women are low in calcium because they don't get enough diet. And calcium is something that has been studied, and there are a number of studies that support it being a very effective treatment for PMS. And we don't often see this in nutrition research. Like we'll look at a population and say, oh, these people don't have enough of this nutrient, but then we give them that nutrient and we don't actually see magical things happen. But with calcium, we do. PMS responds really well to calcium. And so that can be through diet or it can be through a supplement if we're not able to get it through diet. So of course, the vitamin D and calcium relate to bone health, cardiometabolic health, and body composition and weight. I mean, that's where I really focus on nutrition and lifestyle. I don't necessarily use supplements there, with the exception of things like fish oil, good quality omega-3s, magnesium supplements come into play there as well. I'm probably missing something, but those are my big go-tos. For memory, there are some herbs that may help with enhancing memory, rosemary being one of them, and bacopa being another one. And again, a good quality fish oil, getting enough omega-3 fats to support your brain function. Mood symptoms. So, and this can relate to PMS, mood problems relating to PMS, cyclical mood problems, or if you just independently have anxiety or depressive symptoms, there are some really great natural substances there. So I don't always go straight to, oh, you need an antidepressant, although I'm not opposed to antidepressants because they could really be life-saving. But saffron, that spice that's so expensive, saffron as a supplement is actually, has some good data on being safe and effective for managing PMDD and mild to moderate depression. So that's a cool thing to look at. And fish oil, again, high dose omega-3 fish oil, if you're not getting it through diet, supplementing that can also support mood. St. John's wort, it's our herbal Prozac. It does work. Some people are better off taking a pharmaceutical. Some people opt for St. John's wort. St. John's wort interacts with a lot of things, so you have to be careful if you take that. But it is supported by the literature to be an effective treatment for anxiety and depression, more so depression, sorry. And then with respect to anxiety, adaptogens are great. L-theanine is great for that too. Ashwagandha is probably my most used herb for managing anxiety. And we talked about sleep, melatonin being important there. Vasomotor symptoms, I think I touched upon that. Black cohosh, it'll probably help a bit if your symptoms are mild. If your symptoms are moderate or worse, you really should opt for hormones because you're getting more cardiovascular protection. Mild to moderate symptoms, moisturizers, lubrication might give you a bit of relief. But again, if you're getting moderate or severe vaginal dryness or pain with intercourse, you really need to be looking at locally applied estrogen or systemic if necessary, if there are other indications for it. Any specific concerns that you are interested in? And again, this relates to, and I'm sorry, I probably didn't repeat the question again, but the question was other options that are non-hormonal relating to managing perimenopausal and menopausal symptoms. Anything specific that you want to pick my brain about? Yes, Sarah. Yeah.
Like a lot of the information that you're talking about is like 2022.
Yeah.
Right? Like all that whole conference that just happened.
Yeah.
Last year, right?
That's right.
So a lot of perhaps family doctors we would be going to talk about this, or even practitioners don't have this information yet.
That's right.
Do you know, other than I know you've got Kara, right?
That's right. Yeah.
Like guides that would be able to prescribe for people that were interested that you know that would maybe have the most current information.
I do know a few other people. So Dr. Kara Dionisia, who is in Owen Sound, she's actually she's a colleague of mine, was a classmate of mine, and she's actually an educator now, in addition to being a fantastic clinician focusing on women's health. But she actually has is creating and delivering educational content. So this talk wouldn't have been possible had I not attended like a number of I don't know how many hours of continuing education with her in 2022. So she's fantastic. She's NAMS certified, so North American Menopause Society certified, meaning she is up to speed, up to date. She also has an associate, Bronwyn Hill, who's a local naturopath, but they practice virtually. They're able to see a lot of women virtually. They also have physical office space if necessary for doing your women's health exams. And then Jordan Robertson, Dr. Jordan Robertson in Burlington. She has a women's health focus as well and is very much up to speed on evidence-based integrative care. So she's also a naturopathic doctor, but very much an evidence-based naturopathic doctor up to speed on managing women in menopause. That's right, Dr. Jordan, ND. Yeah. She is awesome. She's so funny. Yeah, I think I just shared one of her stories before coming here tonight, and she was actually also one of my classmates and one of my buddies back in school. So, and she's brilliant. She actually has a background in critical appraisal. So her undergraduate degree was all about how to become an expert at like interpreting medical research and making clinical decisions. So she actually has a educational platform that I subscribe to myself for most of my continuing education that is evidence-based, focused on integrative care. And she has a team in Burlington. So other practitioners who work with her would be good to connect with. As I said, I'm not able to prescribe hormone therapy. I'm able to advocate for my patients and have conversations about it with them. But the other resource I would give you is the NAMS, I think it's menopause.org. They have a directory for listing all the practitioners who are certified through them to who you can search that directory. Some naturopaths, mostly, however, medical doctors and nurse practitioners, and of course gynecologists would be on there too. So if you look at that list, you'll be able to find somebody who's really up to date on the topic. Her last name is Robertson. Yeah, I highly recommend following her on Instagram. She's got a lot of really great content. I actually put her on page 4. She's on page 4. I forgot. Yeah, she's on page 4. She has a podcast called Women's Health Unplugged. Yeah, great podcast, lots of topics that pertain to women's health. And it's all really great, reliable evidence-based information. So my profession is very eclectic, and And there are certainly a lot of things that happen within my profession that are not necessarily evidence-based, but there is this kind of uprising of naturopaths who are really embracing, applying, oh, bye. Thanks for coming, Justina. There's definitely this movement within my profession to bring more evidence-based care into integrative healthcare, which I think is really important. So any other questions? Yeah, of course. Yeah. Okay.
In regards to
Okay. Yeah.
and estrogen that is
Mhm.
was not brands, different,
Yeah.
I guess, levels of estrogen that put into it.
Mhm.
I guess my first question is, A, can taking birth control prolong the onset of menopause or perimenopause?
That is a very good question.
And yeah, and I guess the other question would be, how do you know what are the optimal levels if you're
Mhm.
taking birth control?
Yeah. So I'm going to repeat the question.
You're not necessarily showing symptoms, like you're
Right. Yeah. So the question is about birth control pills. And when, oh my God, my brain's getting foggy. I'm so sorry. when should you, or can birth control pills prolong your transition into menopause? And the other part of the question was, how do you know if your levels?
you start taking it
Yeah.
when you're a teenager and then stop
Right.
and go back on it again, which
Yeah.
is continued on for
Mhm.
different levels.
Right. Yeah.
How is that affecting
Your menopause. It's a good question. I don't know if I have all the answers for that, but the question is about birth control pill. And thank you everyone for coming. Yeah. And how does that affect your menopause? And so when you're going through perimenopause and you're having potentially wonky periods and cycles, the birth control pill will regulate things, but it doesn't necessarily make you like prolong your time, your reproductive career. So as far as I know, and correct me if I'm wrong if anyone knows otherwise, but I don't think the birth control pill will like prolong your reproductive career or push off menopause. You'll still go through menopause when your body decides to, but the birth control pill would be regulating your periods. You're less likely to experience some of the extremely heavy bleeding and irregularity that women experience. Yeah. And one of the things I would say about that is that I don't think I talked about the hormone releasing IUD and a really good option for contraception. It's a lot safer than the birth control pill. The birth control pill does have some risks because it's an oral estrogen. It affects blood clotting. It also has a lot of benefits, like not getting pregnant when you don't want to get pregnant, and regulating your cycle. It is one of the things that can do that. There are other things that can do that too, potentially, but the hormone releasing IUD is something that's associated with a reduced risk of endometrial cancer. So that is something that is, it takes away the need to take hormones orally or the estrogen orally, which may be problematic in some cases. But still gives a woman contraception if she needs it, because you can get pregnant right up until you go through menopause. You're still ovulating once in a while, so we can get those pregnancies. Does that adequately answer your question? Or okay, yeah. If there's anything else I didn't quite answer, feel free to ask another question. Yeah.
So it was just sort of similar, and then
Yeah.
there with the IUD discussion.
Yeah.
So when an IUD, whatnot, that is giving
Mhm.
progesterone and things like that. How are you able then to know what hormone therapies that she would potentially need if she's already getting this sort of release happening to make, but she's still symptomatic with the other, I don't know, whatever her experience is. How would you advise?
So that's a good question. So the question is about if you're using birth control, how would you know if you need to access menopausal hormone therapy? So you may not know, because if you're taking an oral contraceptive that's giving you estrogen, that will actually take care of some of the symptoms. So because you're not experiencing that drop off in estrogen, you're actually supplementing estrogen, you're going to be less likely to have some of those symptoms. At a certain point in time, however, you would just stop having periods, and or those symptoms might become unmanageable. You might start to actually have symptoms, but being on an oral contraceptive pill that's giving you estrogen would actually manage some of those symptoms for a period of time, but it would have a different risk profile because you're using oral estrogen. So at some point in time, depending on your age, if you're approaching the age that we expect you to go through menopause, it might be a good time to transition over to a cyclical menopausal hormone therapy, where we're using an estrogen patch or an estrogen transdermal cream or gel, and a oral micronized progesterone or a Mirena IUD to give you the progesterone uterine protection if you need that. So it's sort of like in and around that, as you're getting closer to menopause, would be a good time to switch over to that. And then you can cycle that with your periods. So if you're still having periods, you can cycle that. You take estrogen all the time, but you take progesterone just half the month, like the second half of your cycle. And then once you stop having periods, you can switch over to doing both continuously, estrogen and progesterone all the time.
Even if you're not taking the oral contraceptive and you're doing an IUD,
Yeah.
instead, would you suggest then supplementing with the estrogen because you're getting the progesterone through the IUD?
That's right. Absolutely. So you would, using the IUD, you would either not be having any periods, or you'd be having really like light, scanty periods, which can be a really great treatment if you are unable to gain control over heavy periods with other non-drug, non-hormonal treatments. There are things that can sometimes work really well, but sometimes it's not just an iron deficiency. You might have fibroids, you might have other reasons why you're having excessive menstrual bleeding. The IUD can be really life-changing for that. So the IUD, it's a progestogen releasing IUD, so it's not giving you any estrogen. You'll still start to get symptoms related to estrogen decline. But the IUD works really well to protect your uterus. So you can use the IUD, start using estrogen in addition to that, again, as a transdermal or a patch. Yeah, you're welcome. Yes, you have a question.
I have two questions. The first, as you were chatting, you kind of seemed to be biased maybe towards the like down patch. Is that like cream or suppository, like a pill form, or?
There are a few different options for local or vaginal estrogen. So you can get there is a gel or cream, tablets, and there's also a ring. So a ring that's just like it's inserted and it just stays there. It keeps itself in place and releases estrogen locally. So all of those are good options. I wouldn't say that I think one is better than the other. Yeah.
So the second part of that question then is
the question, so I'm just going to repeat it for the recording. The question was about the different types of locally applied vaginal estrogen is one superior to the other. So as far as I know, they're all the same. And the other part of your question.
The other part is, so if you've been prescribed hormone therapy, estrogen based, should they also, because you're talking about progesterone then, should they also be automatically prescribing that as well, or they just give you that? And if you have other rebound symptoms that then they could prescribe progesterone, or should it be a package deal?
It should be a package deal. So if you are offered estrogen, if you have a uterus, you need progesterone. If you don't have a uterus, if you've had a hysterectomy, whether it's a partial or complete, if your uterus is not with you anymore, you don't need progesterone to protect your uterus. But progesterone does have other benefits. So it can help with sleep, and there are some other benefits. But sleep is like the main benefit we see. So if you are ever offered estrogen, unless it's vaginal estrogen, you can do without progesterone, it is safe. But any form of estrogen, whether it's oral or transdermal patches or gels or creams, those need to be paired with progesterone. And it needs to be oral progesterone or a Mirena IUD, a progesterone releasing IUD. You can't use transdermal progesterone, but I see it done all the time. But you should be gaining access to progesterone at the same time to protect your uterus. And that is very clear in the clinical guidelines.
Unless you're on the vaginal.
That's right. If you're using local estrogen, you don't have to worry about progesterone. You could still access progesterone if it would give you additional benefits, like for sleep, for example. That's a good reason to consider using that if other treatments for sleep are not effective. So, welcome. Yes, Leslie.
If you are taking estrogen, progesterone to try to help with sleep issues,
Yeah.
and you say it takes a while to help with sleep, can you still take
Yes, you can still take melatonin. So the question is, yeah, I love melatonin. The question is, if you're taking estrogen and progesterone, menopausal therapy for sleep, can you also take melatonin? Absolutely. There are really few contraindications for melatonin. Always check with your provider, of course, to know your full health history, but melatonin is fantastic. You do make it on your own if you're in darkness, but a lot of us don't have enough darkness exposure to get that melatonin at an optimal level. And especially women who work shift work, they have an increased risk of breast cancer. We think it might be related to their also very low levels of melatonin, which have also been shown to be a thing in studies. So melatonin has highly antioxidant effects. One of the things that melatonin does is actually help your body repair your DNA while you're sleeping. So yeah, and it protects your lungs and it's an immune stimulant. It does some cool things. So absolutely, melatonin. And if you have trouble with sleep onset, you should take your melatonin like 2 or 3 hours before bed. If you fall asleep, no problem, but you wake up in the middle of the night, you can take your melatonin a bit later. And if it does not do the trick and you're still having some crazy sleep issues, we should talk other things, whether that's hormone therapy or other strategies like exercise, like stress management, like adaptogen herbs. So many great questions. I really having so much fun. I'm happy to answer more if there are any more questions, or if you're excited to get home, you're welcome to head. I've talked your ears off. Cool. Okay. Oh, and I think everyone online is like, thanks everyone at home.